With great pride, I welcome Dr. Fiona D'Souza. She is a wonderful person, and she's also a geneticist, head scientific operations, Anderson Diagnostics Private Limited. And she's also associate professor at IERS Mysore and an industry expert for human genetics, SRM Institute of Technology, Science and Technology, Chennai. She's also faculty with the Fertilus Academy. All of you know that. And if you look at her qualification, she is a MSc, PhD clinical embryology from Manipal Institute of Higher Education, Manipal. She also has done a certified program in genetic testing and sequencing technologies from Harvard Medical School, USA. And she has over 16 years of experience in reproductive genetics. Dr. Fiona has 13 publications in very high impact journals, and she has authored a number of books on PGT, genetic counseling, and preventive genetics. If you look at her area of specialization, it is pre-implantation genetic testing, pre-implantation genetic, prenatal genetic diagnosis, as well as preventive genetics. So these are very few words for a person of faculty of Fiona's caliber, and she's a wonderful teacher also. And you realize as she goes on explaining the difficult concepts in a very lucid way. So over to you, Dr. Fiona.
Thank you, Sarabjit sir, for that kind introduction. Let me just share my presentation for today. Is my screen visible?
Yeah, now it's visible, Dr. Fiona.
Yeah. So today we're going to discuss on how biopsy techniques affect PGT results. What are the factors that influence the reports from the genetics lab? So we know that embryo morphology does not correlate with the chromosomal status of the embryo. This is a classic example of appearances are deceptive. A beautiful 4AA grade blastocyst can be aneuploid, and a not so great looking BC grade blastocyst can be euploid and result in a healthy live birth. And this is the purpose PGT is performed in laboratories to assist the utility of euploid embryos despite the morphological characterizations. Now, if you look at the sampling techniques in PGT, it started with the polar body biopsies, moved on to day 3, that is cleavage stage blastomere biopsies, and now toe ectoderm biopsy is the standard of care. There were quite a few limitations with the first two sampling techniques, first being the polar body biopsies only gave an idea of maternal meiotic errors, did not account for the paternally induced errors, as well as could not give any idea on mitotic errors. Those are post-fertilization errors that is acquired by the embryo. Secondly, cleavage stage blastomere biopsy had the challenge of mosaicism. Because the mosaicism was very high, 70% of the embryos were aneuploid, and most of those embryos did retain the ability to develop into euploid blastocysts, and therefore it was discontinued. So toe ectoderm biopsy is the standard protocol now to perform PGT. Of course, PGT based on the T biopsy can help us look at multiple evaluations. It doesn't matter what kind of genetic evaluation you want to perform in the embryo, we can do it. Because it is a single sampling technique, we can do A, SR, M, HLA-C typing, the entire HLA typing of the embryo. All of it can be done with a single toe ectoderm biopsy. So the biopsy process doesn't. I request the participants to mute yourselves. Thank you. So it doesn't matter what kind of test we are planning in the for PGT, but the biopsy procedure remains the same. Now the specific advantage is that now we can take 6 to 8 cell sample from the blastocyst, because at the blastocyst stage on day 5, you generally have about 120 to 135 cells within the blastocyst, depending on its size. And this will allow us to perform multiple evaluations, give us enough amount of DNA as well for multi-tier testing with the single sampling technique. Now, of course, next generation sequencing is the standard analytical platform for PGT 3.0. And this allows us to look at the entire chromosome complements, all 46 chromosomes, helps us look at mosaicism and at deletion duplication events above 10 MB. Now, because of its accuracy, NGS is the platform to be used for PGT. Mainly, we can also work with very little concentration of DNA with NGS, and that is the case with embryos. Now, there are multitude of factors that affect PGT results, starting right from the blastocyst quality, the amount of laser you have used, the T cell number that is used for the biopsy, the integrity of the sample, how well it is being tubed, what is the dilution of the biopsy material, storage techniques, shipping procedures, amplification technique of the genetics lab, and the sequencing quality of the genetics lab. So you can see that only two features are actually pertaining to the genetics lab, and the majority of the features are relying on the IVF laboratory. So a good sampling technique is essential for us to get good PGT results. So when it comes to the selection of blastocysts for PGT, it is ideal to choose expanded blastocysts. And in case your blastocysts have not yet expanded on day 5, do not rush the biopsy process. This is a golden rule of PGT. Early stage blastocysts will have larger TE cells. That means you will take fewer cells. The chances of them lysing are higher, and the quality of the result gets affected. If you have a fully expanded blastocyst, the T cells are smaller and you get reliable sampling without damaging the blastocyst by a lot. Now, ideally, trophectoderm cell quality in the A and B category are preferred for PGT, and the C category is not preferred because there will be compromised cell integrity as well as quality of DNA in the C grade blastocyst. So we can see here, this was a study which looked at the percentage of apoptotic nuclei. That means the number of cells carrying apoptosis based on the grade. So we can see that in the C grade and the D grade blastocysts, the percentage of T cells with apoptosis can range anywhere between 10 to 25% in the C grade versus greater than 25% in the D grade. Apoptosis means the DNA is degrading and it's going to impact your PGT results, and therefore the A and B category are preferred. Now, needless to say, better the quality, better the results, because better the sampling rate. So if you look at the incidence of inconclusive results, this is when you do a biopsy and a PGT result is inconclusive, you do not have the diagnosis for the embryo. And this is also grade dependent. If you see this data, grade C blastocysts have the highest incidence of inconclusive results. And as even if it's a day 5, 6, or 7, if it's in the result inconclusive rate is always going to be on the higher side. Now, PGT also depends upon the number of cells that are biopsied during the procedure. So we can see here that if the number of cells are anywhere less than 5, that may be 4, 3, or 2, the incidence of WGA failure significantly increases. That means that if you're looking at only a 4-cell biopsy of the blastocyst, we're looking at a failure rate of 4%, which is in itself pretty high. And then with 3 and 2, it keeps on increasing. Now, ideally, you should be taking a 6 to 8 cell biopsies. And this group, Zhang et al., also evaluated how the number of cells impact the implantation potential. Because as embryologists, we know that you need to be very careful about number of cells. As geneticists, we are happy, more cells the better. But the responsibility of the embryologist is to ensure adequate sampling, intact sampling, as well as safeguard the blastocyst, because it is the responsibility of the embryologist to also safeguard the viability of the embryo. So we can see here that as the number of cells biopsied increases, so if you look at the greater than 8 cell category, which is the 11 to 15 cell and 16 to 41 cells, it significantly impacts the quality in B and C grade trophectoderm, implantation potential of B and C grade trophectoderm blastocyst. But with the 6 to 8 cells or 1 to 5 cells, there is no significant difference despite the grade of the embryos. So ideally, we stick to 6 to 8 cells and preferably stick to the A and B grade category. If it is a C grade blastocyst that you're going to biopsy, ensure a proper pre-test counseling has been given to the patient and explain to them that this is a C grade embryo. There is a possibility that we can generate a result, but there is also a possibility of, say, 5 to 6% that we may not be able to get a result. In that case, we might have to transfer the embryo without PGT reports. Now, Similar data has also been showed by several other groups that lower the number of cells, higher the percentage of inconclusive results. So what about the sampling? Now, we have learned about the quality of blastocyst and the number of cells, but we need to be able to differentiate between debris and lysed cells versus intact cells. So the ideal PGT biopsy, the trophectoderm biopsy, remains as a cluster of cells together as a single unit. So here we can see there are sharp edges around this entity. So this is a debris. That is how we figure debris out, if there are sharp edges. Now, unfortunately, you can see this only under the inverted microscope, under the micromanipulator. But if you go to the stereo zoom, this debris will not be visible to us. So we need to make sure that you identify the location of the debris and not include it into the sampling cell count. Here you can see the cell, it lacks a cell membrane. That means it has a nucleus inside, but the cell membrane is completely gone. By the time the sample goes into washing, this is a lysed cell, so the DNA is not going to be inserted into the sample. Here you can see there are a lot of cells that are visible, but these are not really cells. These are cytoplasmic aggregates of a lysed cell. So because of the bilipid layer, the cytoplasmic contents will assemble themselves into cell-like structures, which might appear circular in nature, but it is not possible to tube these cells because you need to give minimum 3 washings for the biopsy sample. And by the time you wash these cells, these are washed off. Also, these are cytoplasmic aggregates. They do not have nuclear DNA inside it. So this does not really count as cells when you plan the tubing of such kind of samples. Now, these cytoplasmic aggregates or lysing of cells is also seen in blastocysts that appear to be intact. So when we visualize the embryo and prep it for biopsy, it looks completely beautiful. But by the time we aspirate the cells, you can feel the friction is lost. The cells are fragile. And the minute the biopsy needle aspirates the cells without any pressure, and you release the blastocyst trophectoderm cells from the biopsy needle, they completely scatter across. Those kind of embryos tend to move towards loss in viability, and tubing these samples may not yield result in PGTs. Now, the first sample here is desirable, the second one is small, but still remains as an aggregate. So the chances of you generating results for this is very high. But here you can see that this is a lysed cell. So this is just a skeleton of cells. And here again, this is completely degenerated. These two categories of cells, despite being intact, will not be able to generate a PGT result. So it is important to document the images of your TE biopsies if you want to evaluate what has resulted in proper PGT report versus not. So this helps you run your audits when you're looking at PGT result failures. Now, we need to remember that the sampling clusters are always better and the dissociated cells tend to fail. And also you need to know the site of entry into the blastocyst. Now you need to make sure that the site of entry does not have any other debris around it or cumulus cells. Now, in most cases, we do not have cumulus cells remaining attached to the blastocyst, but in some cases, yes, they will be. And in those cases, even though your inner cell mass is away from the location, you need to make sure that your biopsy needle is not coming anywhere near to cumulus cells, because cumulus cells are extremely sticky. So if they sit inside the droplet of your biopsy, by the time you release the biopsy cells, it can get stuck to your biopsy and then contaminate the PGT result. And this is a significant challenge when it comes to the standard PGT that we do right now. So you can see this blastocyst is a fairly good quality blastocyst. You can do the biopsy and you can see that the user has taken good amount of cells here. But what I would like to highlight is the remaining part of the story. They've done a great job at this biopsy. That's fine. It is intact. The number of cells. What you need to pay attention to is those cells that you can see outside are extruded cells. So if these cells are very easy to aspirate, does not cause any pressure, you can just slide inside and the cells will come. Now, extruded cells tend to be aneuploid or apoptotic in nature. And if these cells are part of your biopsy, you're going to get a skewed PGT result. It may not really be the true finding. That means that you can have a euploid embryo, but the extruded cells are aneuploid. And now you have either mosaicism or a complete aneuploid result. So here the biopsy technique and the location and the site of biopsy makes all the difference in the PGT result. And of course, there is mosaicism as a dilemma, and both the category of conditions that I mentioned earlier, either the cumulus cell contamination or the extruded cell contamination can trigger false mosaicism because it's a sampling issue and the genetics lab will never know about this. Also, there could be the inherent nature of blastocysts to be mosaic. There is nothing any one of us can do about it. This is biological mosaicism, therefore it is interpreted in its own way. Of course, there is a possibility that the inner cell and trophectoderm are different from each other, and this happens only in about 2 to 3% of the cases. It's not very frequent. So judging the trophectoderm biopsy based on the concept of mosaicism is a little bit overrated in my opinion, mainly because we have better technologies now to decipher between the two, though we still can't biopsy the inner cell mass. So that is always going to be a limitation of this sampling technique. So what about the role of the biopsy in mosaicism? So the number of cells you take for the biopsy will directly impact the incidence of mosaicism. So this is an example I have listed out here. Think you have taken a 5-cell biopsy where you have 3 aneuploid cells and 2 euploid cells. Your mosaicism is 60%, and now we label your embryo as a high mosaic. Had the embryologist taken 8 cells and the same 3 aneuploid cells are present, but now the biopsy has 8 cells, and now the percentage has changed to 37%. So now this is a no mosaic embryo. The difference being only the cell number, but your ratio of aneuploid to euploid cell number has changed, and therefore high mosaic embryo I will counsel to not transfer versus a no mosaic embryo counseling is completely different. I'm going to say do a transfer, the live birth rate is good, it is 10% lesser than euploid embryos, let's do an amniocentesis to be on the safer side, but the outcome is largely on the positive side for low mosaics versus high mosaics. And in this process, the patient has now gone into an unnecessary cycle of anxiety and might not choose to transfer this embryo. And this is how sampling number makes a difference on the result. Second option is the use of DNA contamination. So in case you're not following the proper PPE protocol, and quite a few embryologists don't wear gloves during tubing, which is the most important process of the tubing protocol is to wear gloves and complete PPE, because in the IVF lab, wearing the gloves may not be necessary, but the DNA contamination can come from you just shedding DNA from your hand. You may not be able to see it, but the amplification technology is strong enough to amplify it. And if this is an aneuploid embryo and you have your user sample will be euploid, you will definitely trigger mosaicism from the user side into the embryo, and this can trigger abnormalities in the PGT report. So there are certain invisible variables, of course, some that can be helped and some cannot be. But the biological representativeness of the T cells of the whole blastocyst has been a well-researched concept. Multiple studies have been performed with multiple biopsies across the blastocyst and the inner cell mass, and the reproducibility of PGT is still remains accurate for 97 or 98% of the cases. So the possibility of inner cell mass T mosaicism or a difference in the genetic composition is listed at 2 to 3%. It is listed in every genetic lab's report, and this is why PGT-A is a screening list. And you need to read the fine print of every genetic lab, because all of us declare on the reports, declare on your consent forms that this is a listed limitation. Okay. So of course, no embryologist can control what cell cohort you're taking. None of us can see aneuploidy, and this is also going to have a location-based changes. So if you look at this concept, this relies absolutely on mosaicism. That is why mosaicism is not reproducible, but meiotic errors, which are whole chromosome aneuploidies in most cases, some segmental aneuploidies also are reproducible. So now the reproducibility of PGT depends on the type of aneuploidy, not like a general comment saying T biopsy is not representative of the whole embryo. Then the biopsy-induced cellular stress. Now, excessive use of the laser can also damage the cellular integrity of the biopsy. The laser passes through the zona, so definitely blastomere membrane is not a big hurdle, right? So it can also damage the nuclear content. You can cause excessive stress on the biopsy by flicking multiple times, or you can also be performing tubing on a warm bench, right? So the temperature for tubing is actually room temperature. Your embryos are 137, but the biopsy tubing should happen at room temperature, which is 27 degrees. In case the stage of the stereosome, which is usually heated, has not cooled down to 27 degrees, you should not be tubing over there. The reason being, you are using literally 10 microliter of the tubing buffer on an open dish, which is not covered by oil, and you're moving through those buffers. An open dish at 37 degrees will have rapid evaporation, and this can cause hyperosmolar stress on the blastocyst biopsy and therefore compromise its cellular integrity. This again will surface during the sequencing. Again, of course, cell number makes a significant impact. So coming back to the laser, you need to make sure you are not using the laser as a machine gun. The laser is not a machine gun, right? You need to use it exactly at intercell junctions, and that is called efficient utility of the laser. We don't randomly shoot laser shots all over the blastocyst. Also, we fire the laser shot only outside the zona and not inside the zona, because again, it's a 3D structure which we are visualizing in 2D. So every shot that you make is literally making holes in the zona pellucida and damaging other cells unnecessarily. So always use the laser once the biopsied material has come outside the zona, and always use it on intercell junctions, and maybe 2 shots to loosen up the biopsy a little bit on either side, but always once the stretch has been created, that is when you actually shoot the laser. You should be able to achieve loosening of the T cells within 3 to 4 laser shots, maximum 5, and then go with the flicking technique, and this ensures good sample integrity. So what does the genetic lab do from our side? What do we not see? So we need to understand that current PGTA is based on a copy number variation analytical platform, which cannot detect haploidy, triploidy, and any kind of polyploidy. That means if one chromosome is extra or less, these are aneuploidies, which can be picked up by the platform very well. It has got high accuracy, almost above 99%. In our validation, we got almost 100% reproducibility across cell lines and amniotic fluid samples and standard genomic DNA when we tried the PGT platforms. But if the PN check is missed and you are dealing with a 1 PN embryo or 3 PN embryo, the platform cannot differentiate between it and therefore will report it as euploid. So this is something you need to keep in mind. Do not skip PN check when you're planning PGTA. Second is a DNA contamination. So all the labs are performing CNV-based PGT, but they're not doing a contamination check in your sample. And therefore, the responsibility of the embryologist is to make sure exogenous contamination is not happening to the sample. Again, PN check should not be missed, which is important, can influence the result. So when it comes to mosaicism, of course, it could be a true mosaicism, which is biological mosaicism, or could be user-induced mosaicism, or a platform-induced mosaicism. So mainly the user-induced mosaicism are your contamination may be due to sperm sample incorporated into it, maybe a cumulus cell, maybe user DNA, or you've taken extruded cells. All these factors are sampling-related contamination which can trigger mosaicism. Second is the biopsy technique. The biopsy could be stressed out. The tubing can be performed at 37 degrees, damaging the sample integrity. Even that triggers up as mosaicism because it generates noise on the
Fiona,
edges.
your voice is not clear. Dr. Fiona?
Am I clear now?
No. Are you muted?
No, I'm not.
Dr. Saraf, we can hear her clearly, but must be something wrong on your side.
Dr.
I can
Nisha,
hear
can you
her.
hear us?
Yes,
Yeah.
I can hear clearly.
Okay, I'm sorry.
I can hear her clearly. Yeah.
Okay, thank you, Dr. Nisha. Okay, great. So the bioinformatic platforms used can also trigger mosaicism on their own. This is when we deal with lower DNA concentration maybe, and also when we have a very noisy sequence. The noise on the NGS data basically looks like a scribble that you can see here. The more noisier it gets, the higher is the mosaicism pickup, and these are sequencing related artifacts which can trigger mosaicism. So these mosaicism usually come in the low mosaic range, and that is part of the reason the low mosaic embryos tend to have better outcome. And also depends on the number of reads the company is performing for PGTA. So certain companies tend to use lower number of reads.
I can't raise your voice, ma'am.
I think Fiona's voice is very clear. There might be some problem. Everybody else can hear. I can hear very clearly.
Okay.
Very clear. Pranay is also saying it's very clear.
All right. So shall I continue then?
I think so.
Yeah.
Vaishali,
Okay.
many people are saying it's clear.
I'm saying it's
So
clear.
I think you
Okay,
check with
great.
your net connection.
Yeah, thank you so much. Right. So this is a challenge with the analytical pipelines. In case we are dealing with lesser concentration of DNA, you get higher noise. Ideal concentration of DNA we need to get is minimum 10 nanogram. And also, if you have lower number of reads getting onto a sample, you can also get noise. And these noise is what triggers false positive mosaicism. Okay, so contamination can also lead to false positive and false negative results. So let me quickly address this because it's part of something I've already discussed. False positive is when you have sample that was actually euploid but has been wrongly interpreted as aneuploid. This can happen for certain, if you have the extruded cells in, you can have sex chromosome mosaicisms, etc. And also you can have false negative when a completely euploid completely aneuploid embryo has been mixed with the user contamination or a cumulus cell. It can completely mask the aneuploidy and result in embryo that is labeled as euploid transfer, and then you can get a miscarriage with a chromosomal abnormality or an anomalous fetus. So contamination risk is real in laboratories, and there are several studies which have evaluated it, and the reported incidence is anywhere between 0.5% to 7.7% across laboratories. And this was a study done in the US, which has reported this, but in India, no study has been done until now, mainly because the platforms have not been evaluating contamination. So you need to remember that genetics lab is not evaluating contamination in the current platform. So to make sure that we are performing reliable biopsy samples for PGT, we need to make sure that the lab environment is clean, strictly adhere to aseptic protocols. 70% ethanol does not remove DNA contamination, and of course can never be used in the IVF laboratory. So please do not use 70% alcohol to sterilize the environment unless you have a tubing station outside your embryology lab in another sterile room, because we still cannot risk the transfer of VOCs from 70% alcohol because it can move easily across our incubators and affect other growing embryos. We need to make sure that the reagents and consumables you use are certified DNA, RNA, and DNase free. You need to make sure that you're using the kit of the genetics lab and it is handled properly. Make sure that you are using unused sealed tips for tubing and not from refillable boxes. And double witnessing is essential because the genetics lab is completely relying on you labeling the tube correctly and choosing the right embryo for transfer. Both of these are not checked in the while performing PGT. So this was an interesting study I wanted to share because the amplification technology used by the laboratory actually determines the risk of the contamination. So there is always a controversy saying that can we use IVF fertilized embryos, conventionally fertilized embryos versus ICSI embryos for PGT? So the answer is yes, you can use embryos that have undergone conventional IVF, provided you are able to get rid of most of the sperm from the sample, but some of them will be still remain stuck to the blastocyst. There is nothing we can do about it. But most of the common technologies used by the laboratories are either Malvac or Picoplex, which does not significantly amplify sperm DNA. But if the laboratory is using a technique called MDA, MDA is powerful enough to even amplify sperm sample DNA. So it is preferable to avoid IVF fertilized embryos in case your genetics lab is using MDA. You can ask your genetic service provider, they will tell you what amplification technology we are using. It's not a problem at all. Cumulus cells, of course, can be perfectly amplified by all three technologies, and a single cumulus cell is enough to give you good enough concentration to completely mask your data. In fact, there are several studies also that, and certain cases, colleagues from other countries have also told me that they have had cases where a single cumulus cell has completely contaminated the sample and it was an aneuploid embryo. So there was one case from Juno Genetics which had monozomy 15 which was masked. There was one more lab that was telling me the same. So make sure that the cumulus cells are nowhere in contact of the biopsy sample while performing PGT. So tubing related conditions that can result in failure of the PGT report are mainly losing the cells during tubing. Cells can be sticky, it can get stuck to the stripper pipette and never get loaded into the sample at the very last stage. It is always I don't know about the rest of the embryologists, but for me, it is quite difficult to visualize the cells once they go inside the tube because the dynamics of the tube and its visual is quite limited. And therefore, you need to make sure that you're using swift transfer techniques. Second, the biopsy material can begin to dissociate. It is impossible to retain its integrity when it's passing through multiple washing processes. You need to wash it minimum 3 to 4 times in the buffer that is provided by the genetics company, and therefore you can lose the cells in the process. The third most important part is when you introduce air bubbles into the tube. If you introduce air bubbles, the sample can move into the air bubble. And when you freeze the sample, now your biopsy sample is sitting in the air bubble and not in the buffer, and therefore its integrity is then compromised. Amplification will not work. And in case the air bubbles are introduced, tapping the sample does not help, mainly because you might dissociate the tiny droplet that is there. The volume in the tube should be 2 microliter to maximum 3 to 4 microliter. If you load too much of buffer into the tube, it's going to be a challenge, and definitely the PCR WGA will fail. Second most important factor is the amount of buffer that you load into the tube should be followed according to the SOP of the laboratory. Some laboratories tolerate up to 4 or 5 microliters. Some laboratories are very particular to have only 2 microliter of buffer in the tubing solution. So you need to factor in that if the sample is preloaded, you need to be very, very careful to use only minimum volume during transfer of the biopsied cells. Most importantly, embryologists usually, we are taught right from the beginning to load everything from the sides of the tube. But the geneticists usually load top down, always to the center of the tube. So if you've loaded the biopsy on the side of the tube and it's not reached the bottom, it is possible that the WGA reagents don't reach your biopsy at all and sitting on the wall somewhere far away because of the volume related challenges. Therefore, make sure that the sample is tubed right at the bottom of the tube and should not be attached to the walls per se. So make sure also that the cold chain transport of the laboratory is maintained properly. You should check with your genetics lab, how are they transporting the samples? There are 2-3 ways to do this. Usually it will be in a -20 shipper. Usually there can be a rack of -20 or could be charged ice packs around the box, which have to be at -20. So what is important is if you are using a -20 shipper related thing provided by the genetics lab, make sure that the ice packs are stored in -20 at least for a good amount of time, minimum 48 hours, because then only they can retain the temperature. Your regular ice packs will not do the job. The ice pack, ice blocks, the cartridges which are used into the shipper are different from your standard ice packs. So don't supplement it with your regular ice packs. It doesn't work. Use only the blocks that are provided by the genetics company. Keep them clean, frozen in your -20. So if you're using the shipper, you need a -20 in-house. The second option is, of course, to use dry ice. The shipping cost is higher, but maintains the temperature at -80, does not affect your samples. So dry ice can sustain -80 temperature for at least 72 hours. Within 72 hours, you can reach the length and breadth of our country, no matter where your genetics lab is situated. So that's one of the options. Also, make sure that if you're using dry ice, the container must allow the CO2 to escape so that to avoid pressure buildup. So usually there should be some gap within the thermocol box, but not within your kit. You also need to make sure that in the lab, to ensure we have pre-amplification quality checks, we make sure that the successful lysis, there is no way we can visualize this. Okay, we usually add the buffer, keep it for a standard time. And what you should understand from the genetics lab is we don't process one sample at a time. Usually it's a batch of n number of samples depending on our load. So therefore there is a uniform process that is going on. We also make sure to use the internal positive control from the laboratory side and a negative control from the IVF lab side that you provide along with the samples during testing. We will cross-check the tube, buffer, and label verification. So the labeling is crucial. So more often, I have cases where we get labels AAA, BBB, CCC, or 111, 222, or embryo labels that go as 1, 2, 3. And this is very challenging for us because more than one person thinks in the same way, because we receive samples from all over the country. At a certain point, we had 3 cases where all the 3 cases, the embryologist has labeled AAA, BBB, CCC for the embryos. So This is something that should be absolutely avoided. While labeling the samples, it should always be the initials of the husband and the wife. That way, the incidence of it mixing up with another sample is avoided. So only then when it comes here, we can barcode it and run it properly. This is because in PGT, once we do the amplification, all the tubes are separate, but the final sequencing is going on a single chip and can load up to 98 samples in one go. And therefore, the DNA barcodes are added accordingly. If you have similar labels across multiple samples, then it becomes very difficult for us to assign the sample to the patient. And this is why we are very careful when we choose the batch. But from the embryology side, we should make sure that the labeling is correct. And the control labels also should be done correctly. Never label on the side of the tube because it gets wiped out. Always label on the top of the tube. That is the coarse edge where you can actually retain the label. Now, whole genome amplification is evaluated first with total DNA yield. First WGA, we need minimum 10 nanogram. So if you get lower than 10 nanogram, the data noise is always higher, and then you have challenges. So also there is the allelic based indicators, allele dropout risk evaluation for PGT-M alone. We also look at depth uniformity, the coverage distribution, and we also have a parameter called NAPD, which gives us the quality of the data assessment. Only after it is passed, we will generate the PGT report. So we will look at total mappable reads and the alignment. That means a sample of PGT is maybe read 2 lakh times, 2 million times, 3 million times, or maybe even more. Once we get those reads, they're mapped to the human genome database, which is set in the system. So we need to make sure that the productive read count is good enough for us to report it. Coverage uniformity will also be addressed, and we will check our noise threshold. So usually we set a baseline of mosaicism pickup at 30% because below 30% the data noise is more and the false calling will be higher, and therefore the reportability of mosaicism starts at 30% for us. Until 70 to 80% we can take it up. So here is a case where we had we need minimum 1.5 million reads, 150,000 reads, which are mapped to the genome. In case this fails, we have here called as value called as MAPD value. This has to be inside a particular limit. So usually it should be below 0.2, and if it is very high, then it means that the data integrity is compromised. You can look at this sequence. I can see here there is an aneuploidy, but because the MAPD is high, now this result is no longer reportable. So even though I have a result, it is not reliable. It could be just data noise triggering the aneuploidy. And if I choose to report, these are the cases where you get false positive aneuploid calls. So when a laboratory is strict on the cutoff of its data quality, you might get inconclusive results, but it will prevent the reporting of false positive results. And it is important that these chromosomes align on a straight line. That is the best quality report that you can get. Slight movement is okay as long as the MAPD value is within limits. So here you can see this case, we have 25 nanogram concentration. And you can see this data noise is very, very noisy. And they're scattered all over. We had less than 30% mappable reads here. The MAPD value was 0.7. So this was a QC fail. This result cannot be reported at all. So to somebody who doesn't know about this, it might look like all are aneuploid, but it is not the case. Here there is a DNA contamination definitely. And we're not getting mappable reads to the human genome. So it could be a microorganism based contamination. And it is not reliable therefore for us to report it. So if you look at the results of PGT, they're mainly determined by the amplification, the yield, the depth of the sequencing, the quality of the data, and its coverage, but it's also affected by the contamination control and the biopsy technique. So all these factors are all important pillars of generating a good PGT result, and none of them can be excluded per se. So to conclude, it's important that we have proper genetic counseling before PGT for patients, because PGT has its own limitations. Patients should be aware what they're getting into. Quite often when we do post-test counseling, when the patients come to us, they say that we never knew about all these limitations because the limitations are long. But we need to take the time to explain patients that PGT has limitations. We make sure that the patient is convinced that this is not a test which guarantees you a pregnancy, but it is a useful test to reduce the time to pregnancy and reduce the risk of miscarriage. This is the purpose of PGT. The perfect derm biopsy is a standard practice now. We no longer process polar bodies or cleavage still samples. And there is a possibility of about 2% of inconclusive results. Each laboratory has their own metrics, and we do evaluate our outcomes frequently to see how the inconclusive results change from center to center. There's a huge variability, you can see, and it also depends on the quality of the embryo. So clear, transparent communication with the genetics lab helps us assess the cause behind the inconclusive results instead of just assuming a standard list of parameters. And inconclusive counseling to patients also is important because rebiopsy is always an option, but it can also compromise the quality and viability of the blastocyst. And that is why we have to consider rebiopsy carefully. There are multitude of studies which have evaluated this parameter as well. So we need to be careful by interpreting these results depending on what the laboratory is, how the biopsy has been performed versus how the testing has been. Thank you. We are open to questions if any. Okay, I have a question from Pranay. How to handle losing cells during tubing? What extra precautions can be taken? Okay, so losing cells during tubing is very easy because the advantage of the micromanipulator is you can see everything clearly, but that's not the case with the stereosome. So first thing is mainly don't load the biopsy directly to the base of the droplet. Because if you load it to the complete bottom of the droplet, it will get stuck. Second, if you load it on the very surface of the washing droplet, you can actually, the biopsy can move to the edge of the droplet. So the difficulty is, since the washing dish is not covered by oil, you will not be able to visualize that biopsy samples easily in case it moves to the corner. So we need to avoid the shadows. So make sure that the biopsy sample is loaded just 2 millimeters below the surface of the tube of the droplet. Second, move through the washing process as soon as possible. Don't keep it and wait, because if you keep it and wait, the biopsy can go down and get stuck. Third, before starting the washing process, make sure you rinse the stripper pipette 3 to 4 times with the biopsy tubing buffer, not biopsy buffer, tubing buffer, because this will help to make sure that the biopsy doesn't get stuck to the stripper pipette. Fourth, don't use very large stripper pipettes. Use the smaller ones, which will be, I think, 135 will be ideal for the biopsy washing, because larger stripper pipettes will have more buffer volume coming in, and again the biopsy can get lost, or you will end up tubing more buffer than required. So these are the few things you can do. But some blastocysts are inherently sticky. No matter what we do, we can't really fix the problem. So in certain cases, it can just get stuck. We will have to rebiopsy in that case. We cannot avoid the sticky nature of key cells.
Right.
Any other questions?
Fiona,
Dr.
excellent.
Fiona.
Yeah. Dr. Nisha,
Yeah, excellent talk. Fiona is an excellent speaker, and it's a pleasure listening to each talk of hers. Dr. Fiona, from the clinician point of view, how would we know that, we are not performing biopsies, we are not doing that? So from the clinician point of view, even I would request everyone to mute themselves, please.
Just a minute, ma'am. I can just mute all participants and then you can unmute yourself maybe. Okay, it's
Yeah. Can you hear me? Yeah. Can you hear me?
Ma'am, can you unmute yourself now and do? I just muted all participants.
Yeah, I can. Can you hear me now? Yeah, okay. So we have this process of getting, the embryologist verified and getting from good labs also certified that they can do biopsy. But each and every time, is there some bench parameter or something which we can check that if so many samples are taken and so many are not good or so many are good, so then we don't need to check the embryologist? I mean, what is the parameter? How do we check that from the clinician point of view that nothing is going wrong? It's like, basically, because see, I think too many samples coming aneuploid is not to do with the embryologist, right? Because
Yes,
that could be a
correct.
patient factor also. So what
Yes.
is the parameter which we need to check?
Okay. First thing, let me address the aneuploidy part. So the embryologist cannot induce aneuploidy. There
Yes.
is only data noise which can come as mosaicism. So the embryologist is not doing anything to induce aneuploidy. The stimulation protocol also, in my opinion, does not induce aneuploidy per se. These are mainly mitotic and meiotic errors. Second, regarding the embryologist validation, this is something that I frequently say: don't trust the genetics lab for the validation. What the genetics lab is doing is they're just evaluating if we have enough DNA in the biopsy samples. But you should be more focused on the process of the biopsy as opposed to yielding the DNA. So during the biopsy validation process, the fact is you can give us half the sample, right? We are doing validation with square blastocyst. Even if you take half the biopsy and put it into the tube, the genetics lab can never visualize the biopsy. So none of us are checking on that point. We are blindly just evaluating the amplification feasibility of the sample. So what the genetics lab validation certificate says that the embryologist has given us enough cells and we have generated enough DNA. Nobody is vouching for the embryologist biopsy skills. So the diagnostics lab validation certificate is not a foolproof evidence of the embryologist's efficacy to perform biopsy.
Great. Nice to know that.
You need to validate the embryologist. Validate the embryologist under a senior, experienced embryologist who can see the process, who can troubleshoot problems, who can give tips to improve the biopsy process. And then you rely on that person's comments and inputs as opposed to just a certificate. I have given certificate for so many people, ma'am. I've seen so many certificates from everyone. And this is just a namesake piece of paper, which in my opinion has no value. The skill of the embryologist is only going to determine the viability of the embryo. The most important part is not just getting enough DNA. The important part is the embryo should survive the biopsy process, survive the freeze-thaw process, and give you a healthy live birth. In case the biopsy is traumatic, there itself we will face implantation failure or miscarriage. So the process is more important than the result, in my opinion.
Yeah, I agree. But still, like, you mean to say that the only way to certify is with a senior embryologist, right?
Yes.
Okay.
So now you have AS, IFS who are coming up with validation programs, certification programs, which I think will be more reliable now.
Okay. Thank you.
Hello?
Thank you so much.
Hello?
Thank you.
Yes, ma'am. Thank you.
Hello?
Yes, ma'am. Please tell me.
Can you hear me, Fiona?
Yeah, I can, ma'am.
Yeah, you very well pointed out that the genetics lab validation is not the certificate for embryo biopsy for the embryologist. One thing I would like to add that even if under the senior embryologist the person is performing the biopsy, one should look for the viability of the embryos. They can work on the surplus embryos which are being discarded and see the viability of the post biopsy. How many are surviving? How many are expanding? So that can add to their KPI values how they are doing the biopsy. Because I have seen many people, embryologists, they think the amplification should not fail from the lab, otherwise the clinician will shout at them. But the point is, in that process, they pull out so many cells that the viability is compromised. So that is one point which I wanted to add.
Yes, ma'am, absolutely. That is very, very important fact that the embryo viability is more important. So we usually, what we see is we look at the re-expansion of the embryo. We look at the images at least 3 hours post biopsy, maybe more.
Yeah, right. Yes. Yeah,
because
thank you.
also
You have pointed out all the important points, Fiona. Very well said.
Thank you, ma'am. Thank you. Even the volume of buffer into the tube also matters. Quite often we get more volume than is anticipated. So there is no way for us to remove the buffer from the tube. I mean, I can use a pipette and do that, but how do I know that the biopsy is not coming out with the sample? So
Yeah.
excessive volume of buffer into the tube also it will immediately dilute the lysis buffer, every primer that is
Exactly.
coming in after
Yes,
that.
yes.
It's
Yeah.
not a problem
Right.
that can be.
But the problem is that it is a very each some obviously even the most experienced person may find problem somewhere, but we as a clinician have no way of defining that this was right or this was wrong, or it has to be just trust the process only. So
Yeah.
I was looking for, even there could not be any are there any parameters for out of 10 biopsies, I don't think, because it's different, each blastocyst, each cells, each technique, each, even you explained that even in the best of the hands the some cells can stick because it's the nature of the, so from the, I don't know, just I think it's more like IVF, it goes on faith only.
Yeah, and also globally, what we see in all laboratories and all the papers that are published, the incidence of WGA failure is anywhere between 1% to up to 3 to 4%. So that is the general range where things happen. So
Can you please explain? 1 to 5% means like
1 to
there will be
4% of
no
the
DNA.
biopsies
Uh-huh.
they will be insufficient DNA, inconclusive
Okay.
results.
Okay. 1 to 4% is the
Yes,
benchmark.
yes, that is the range usually. Okay, I will take a few questions in the chat box. Dr. Lucky is asking, what are the signs you would notice when an embryo's morphology is not correcting with chromosomal? That's always the case. Morphology and chromosomal complements have no connection at all. It moves according to the biological variation. So perfectly great embryo can be aneuploid and a poor quality embryo can be euploid. And it's quite common. There's nothing we can do about it. That is the reason PGT is in the picture. How embryologists can influence PGT results such as no DNA detected, no mosaicism. I think the entire talk has been focused on this. So mainly avoid humulus cells, avoid extruder cells, avoid excessive use of laser, avoid very harsh flicking techniques. You need to practice on it and make sure that the tubing is done as quickly as possible. Make sure the tubing is done in room temperature stage and not 37 degrees or 34 degrees. All of these factors matter. Don't over dilute the sample. These are some of the things you can take care to avoid no DNA detected or inducing mosaicism. And also one more thing is when an embryologist is validated under a senior embryologist with the genetics lab, you need to make sure that either the embryologist has primarily practiced at least good number of biopsies and they slowly start doing clinical cases. It is not like you do a training today, you attend a workshop and you suddenly start doing biopsy the next day saying that you're certified. The number of cases you have performed, the survival, the images will all help as an embryologist, document these things so that when you go to another lab or talk to a clinician, you say that this is my process, this is my logbook, these are the outcomes that have been done. If you have images and dates, you have documentation, that will help better than anything else. So keep images always because this will help us to troubleshoot what has gone wrong and also help the clinician get confidence on the biopsy scale. All right. If there aren't any more questions.
Yeah, great. It was great, Fiona, as usual. I think you have explained every part very well, and I'm so happy for this demo class. Thank you so much. Thank you so much.
Thank you. So thank you everyone for all your time. You will get the details of the upcoming course. We will address all these problems in detail. Do join us.
Thank you,
Yeah, thank you,
Fiona.
Fiona, for that wonderful session. And just a gentle reminder that today is the last date for registering for the course, and the course starts on Wednesday. I hope my voice is clear.
Yes, sir. You're clear.
Okay, thank you, Fiona, for this wonderful,
Dr.
extremely wonderful session. Actually.
Thank you. Good night. Thank you.
Thank you. Good night. Good night. Bye.